So I haven't been here for a while either. This was a interesting case that we had a few days ago, and of a woman who was undergoing a TAVI, and during the procedure they were inflating the balloon, and all of a sudden there was no pressure left. The meter just said there was no pressure when they were inflating. The woman immediately coded, and they did an echo, saw a massive amount of hemopericardium. They put in a drain, cracked her chest, and I'll show you what this surgeon saw, which I think is very interesting. This they didn't see. So this is a interesting complication post-TAVI, where she developed a communication between her valve plane and her RVOT. So you can see this little iatrogenic fistula. We're not really sure how this happened. We assume that clearly there was something that ruptured from the annulus and drained into the RV, if it was a piece of calcium or something. That they didn't see. What they did see is when they cracked her chest open in the suite, they saw this, which I think is really interesting. So the surgeon basically picked up the heart, kind of, according to him, kind of lifted it up, looked at it, and basically said the whole RV was hemorrhaged. Like there was just blood everywhere. But it wasn't hemopericardium. It was epicardial. It was between the visceral layer of the pericardium and the myocardium itself. And what you can see here, which is very interesting, is all this hemorrhage exquisitely surrounding the whole course of the RCA. So somehow this woman, because of such high pressures from this aortic rupture from the TAVI, somehow this blood dissected and went, not only fistula, caused a fistula, which was one injury, but then the hemorrhage that went from presumably the aortic root and just dissected around this whole course of the RCA. So this is, epicardial hemorrhage, just track. And no one had ever seen this. We're not really sure why the blood chose to go down that path. I guess it was the path of least resistance. And interestingly, the surgeon said there was just blood all over the right heart, and the left side looked fine, it is fine. So a couple interesting complications post-TAVI. She actually did fine. She is extubated. She's awake. She has her valve. She does have a fistula, which they didn't see and are not going to close. It's small at this time, and they're going to watch it. So that was an interesting case, to say the least. And this was the next day, another aorta case that is not as interesting, but pretty impressive. This is a guy who had a aortic valve, ascending aortic replacement with coronary reimplantation, and presented with worsening dyspnea. And we can see here that there's just complete, I don't know, we didn't even know what to call this, just melting away, dehiscence, rupture. I mean, the graft is just gone. I mean, that's not fair. It's there, but needless to say, it's leaking badly from somewhere, probably around the annulus, although there are a couple sites that could have been areas of hemorrhage. But you could just see this just dramatic hemorrhage all throughout the surrounding the aorta, also extending into intrapericardially into the epicardium. What's interesting about this, and one that my fellow pointed out, which is unrelated, which I thought was really nice, and I have only seen one other case, and I didn't think it was as pretty as this, is this guy has a very pretty, I don't know what to put into this, but has a very pretty napkin ring sign. So we talk about the sign for, theoretically thin cap fibroatheromas, i.e., potentially vulnerable plaques, with its napkin ring sign, where this is not calcification. This is supposedly enhancing fibrous, I don't know, enhancing, if it's this and this is the fibrous cap and necrotic core, or this is the necrotic core, then this has to be some portion of the adventitia or media that it's enhancing. Anyways, that's a napkin ring sign. But so it has two things here, the aortic dehiscence and that. And then lastly,
Seth, are you guys using CAD-RADs since Charlie's? He's on that paper, right?
Yeah, I laugh about that to him. So, I said whatever. I mean, people are listening to this. We could talk about that privately, but basically, CAD-RADs has taken the fact that we call things minimal, mild, moderate, severe, and giving it numbers.
Well, I like the fact that they talk about vulnerability in two-feature positive plaque.
Yeah.
Like the napkin ring and low attenuation plaque, but yeah.
Right, and I mean, you should talk about that anyways, but yeah, I agree. But, you know, when they talk about CAD-RAD 1, it's basically minimal stenosis, and CAD-RAD 4 is severe stenosis.
No, I agree with that.
Yeah. But yeah, there's the other, right, they do talk about vulnerable plaque, and we should be looking for that as it is. But yeah, they do. I kind of give Charlie crap about that one. Anyways. And this one, I'd be curious to see what people think about this. This is not anything that it doesn't really matter. Is what would you call this large fatty deposit here? You know, it's somewhere, you know, rising from the epicardial fat, or is it, you know, I thought it was arising kind of from the region of the intraatrial septum, although it extends kind of anteriorly instead of the classic. I thought it kind of may start back here and kind of extend, but I don't know if, it doesn't matter. No one's ever going to do anything about it. You know, it's not a lipoma because the vessels are going through this whole thing. If people would call this lipomatous hypertrophy, that is just going in a strange direction. This is up for any thought or discussion. Again, doesn't really matter in the long run, but I thought maybe this could be a portion where this is the vessel portion, this is a lipoma back here. Do people think it's a lipoma? Do people think it's lipomatous hypertrophy? And any thoughts?
I agree with you. I think it's probably not a lipoma, even though I can imagine some people would try and say that it's encapsulated. I think it's probably just a variant of lipomatous hypertrophy, but I don't know if it matters.
Yeah, no, it doesn't matter. And we were not really debating, just kind of wondering what other people would think about it. Not too exciting of a case. But, yeah, those are mine.
Yeah, I don't recall seeing one in that particular location. I've seen mediastinal so-called lipomas in other places, but not quite there. So I wouldn't know what to call it either in terms of a name. Either.
Yeah, it would be like an epicardial, you know, it's within the pericardium. It would be an epicardial lipoma or something. I don't know. And we're never going to find out. She's got metastatic cancer. She's got clearly other issues going on, but kind of interesting look.
Yeah, really.
All right, Howard, I can show some if you want, or you can go.
Okay, I'm going to change
You're just going to have to.
You, Trevor.
Okay.
You haven't been on for a while. So here you go.
All right. Okay, you see my screen?
Good.
I've got a few valve cases too. This is one that's just interesting because this is the first time I've seen this type of valve. I've seen two of these this week. The first one I saw at the VA on Tuesday, and I thought at first that you can see there's a stented bioprosthetic valve, and I actually thought at first this was going to be a valve-in-valve, like a TAVR inside of one. But it turns out this was all placed at the same time, and this is a new type of bioprosthetic valve. I'm curious if anyone else has seen this before, because it looks like it has a little mesh portion inferiorly. It's more in the aortic, the LV outflow tract, and then it has the 3 prongs like we normally see with stented bioprosthetic valves.
Yeah, I saw one week by pure chance, just like that. And I did look up the name, but I looked at the op report, but I completely forgot. Yeah, Intuit.
Yeah, so,
that's it. Yep.
Right. So, yeah, again, I have no financial relationship to Edwards, but this is some new kind of a hybrid almost. It's called this Intuity, and so it is a stented bioprosthetic valve, but it also has components that are expandable in the outflow tract, like you see here. So it's kind of half TAVR, half bioprosthetic valve. And so I was reading the operative note, they put 3 sutures to anchor the root in, and then they expand this portion. In this, they have some delivery device. So they still do a median sternotomy, but they can do a fairly small aortotomy and then deploy this thing. So I had never seen one of these, and now I've seen 2 this week. So I thought it was just interesting because like I said, I had confused it for a valve-in valve at first. So I don't know, Seth, have you seen one of those?
No.
Yeah, I thought this was interesting. So there are a couple of, oops, I need to go to their website. Yeah, there's a video that shows it being deployed and everything, but I just thought that was a curiosity, an interesting new valve. So I'm going to start with this case to set up the other ones. This is an old case, but I think it's a great example. This is a lady who looked fine. This is, as you can see, this is a long time ago, but I came across a follow-up radiograph and looked back and thought this was a great example. So she's totally normal, undergoes surgery, and 3 days later has diffuse opacities, and you can see kind of perihilar and lower lobe, these hazy, more alveolar opacities, but she does have some curly lines peripherally. Yep. And I like this CT, and I know I've shown cases of this, and Howard has talked more about the physiology than me, but this is one that people tend to overcall pneumonia when they see stuff like this. But you can see there's lots of other findings of interstitial and alveolar edema. You've got septal thickening, you've got fluffy ground glass, and I think, again, this is like a straight air fluid level essentially in the lungs. And so I think all of this is alveolar edema. She was afebrile, and I think as Howard has referred to, this was overhydration. So, you talk about the stress failure of the capillary membranes, which I usually think of in terms of heart failure, but I don't know. Do you think that this could be that mechanism just in the setting of overhydration? Because 2 days later, she looked substantially better, and she was only intubated for a day after the procedure, never was on antibiotics. But I don't know if you have any more you can comment on the physiology, but I think this is just all alveolar edema that tends to pool dependently.
Yeah, I think what's in the dependent lung is basically just edematous but atelectatic lung that's heavy. And if you look at the literature, if this is a question, if you look at the literature on what patients with ARDS have or what their lungs look like, if you do a CT, this is a common finding where substantial opacity in non-aerated lung is present in the dependent lungs, which, if you put the patient prone, would go to the other side.
Right.
Phenomenon of weighty atelectatic lung in patients with acute lung injury is well described.
But she doesn't have any volume loss, or really not a lot of volume loss. I mean, yeah, and it's not enhancing like typical atelectatic lung, so it's probably just boggy or wet atelectatic lung. Is that what you're?
Yeah, perhaps a combination of both.
And she was this is the last radiograph we had before they sent her home, so it could have been permeability, a combination of hydrostatic and permeability edema without diffuse alveolar damage, because this was less than 2 days later and she looks better.
Yeah.
So, yeah. So, but I set that, I used this one just to show, because like I said, I think people love to call, and this was called pneumonia, which I don't think is true. And then I've got a more recent case, and this one.
What was her surgery, Travis? This last person?
I think she was, I don't know. I can't remember. Something in her belly. As you can see, she's got some pneumoperitoneum. I was rushing to put this together. I didn't get a chance to pull up her old op note, but I will and include it. But I show this one next. So this is one I saw last week, as you can see. And this is one where I give my resident credit, because this is a lady who came in, is intubated at this point, but has a very similar appearance on her radiograph. She has probably some peripheral curly lines, but she underwent this CT. This was a dissection protocol, and you'll see that she has findings that my resident favored edema, given how diffuse this was rather than pneumonia with the effusions. And again, some more of this maybe atelectasis here. But as I've told my residents, and I know we've said before, is whenever somebody looks like they have this severe of edema in the acute setting, you really need to figure out why and see if there's an explanation on the CT. In her case, you can see that her left ventricle is dilated. She had no history of any heart disease, and right here is the culprit. And I didn't like, first of all, I didn't like how thick it was between the between the left atrium and the aorta. And then she had this thickness along the non-coronary cusp down at the root. When I looked at the non-contrast, I actually thought, I was worried initially about an intramural hematoma, because there is a little bit of higher attenuation in the wall. She had a simple attenuation pericardial effusion. And so when I talked to the cardiologists, they thought it was more of a vegetation at the aortic root, which I thought was reasonable too, causing floridly incompetent aortic valve and aortic insufficiency in the acute setting. We tried to do a gated study. It's pretty crappy. I'm almost embarrassed to show it. It's one of these crappy scanners we have, but didn't really help anyone to confirm. What'd you say, Seth?
Which one?
What,
Which
the scanner? Oh, it's a G. So, but
an old G, not the Revolution, an older one.
No, it was an HD 750. I hate this scanner.
Well, I'm moving to some of those, and I'm not looking forward to it. I was just.
The Revolution is fine, but
okay.
But anyway, so they took her to surgery because again, I was worried at first about an intramural hematoma, and I thought I saved her report. Let's see. Maybe I have it. Maybe I need to just convert it. Oh, shoot, I thought I had it. But anyway, they found that this was all of huge vegetation. It was involving her aortic root and the thickening of the cusp, which was causing aortic insufficiency. And it was necrotizing granulomatous inflammation with giant cells. So turns out she's not from the United States, and she only went to surgery a couple of days ago, so we don't have any cultures back. Karen said she's seen cases of tuberculous endocarditis before. I've never seen that. I don't know what it's going to turn out to be. I'll let you know when I do. But I think you could see that her edema has already started to improve, and this was done a day after that other study. So again, the take-home story being, if you can, just because you see alveolar stuff doesn't mean it's pneumonia, especially when you have other findings of edema. But this is all just acute edema, and then the explanation was on the CT right here.
Jeez.
So, and these aortic root ones scare the heck out of me for reasons as you see there. I mean, it's pretty subtle if you're not looking for it. And then this one came in a couple of days ago, and this one you can see, this lady has, again, edema. She's had a prior median sternotomy, and I think you can probably, I can't even tell. She has a mitral valve, you can faintly see here. So she had mitral valve endocarditis. She's an intravenous drug user. She's 30. And you can see nice curly lines, subpleural edema in the fissures, peribronchial cuffing. And hers, she had this CT done at the general before she was transferred over here. And sure enough, you can see, and Seth showed a nice example of a stented bioprosthetic valve. And just, these should be the thickness of normal leaflets. They're either xenografts or they're bovine or porcine tissue. But this is all vegetation along this valve. And again, as the explanation for her edema in this case. So she went to surgery. The MR really doesn't add anything to this, I don't think, because this is diagnostic for a big vegetation, and they knew from echo. But yeah, David, I included all of this data for you because they did find that she had pulmonary arteries. She had mitral stenosis from the vegetation. She was staph aureus positive, and then they talked about her gradients and her pulmonary artery pressures that improved. after they, well, I guess just the transmitral pressure, but certainly this was just from acute left-sided pressure elevation from mitral stenosis, and that improved after they replaced her valve again. So that's just a case of mitral vegetation. So we've had a lot of valve cases lately.
Yeah.
Sure.
Now let me show one more. This is just it's a nice radiograph. This is, you can see this guy's young. He has a known diagnosis, and you can see it looks like it's a solitary pulmonary nodule on the PA view. When you look at the lateral view, it's really where you can, let's see if I can using having both up. And you can see it's pancaked here anteriorly, and it's when you really zoom in that you start to see, looks like there's couple little tubular things going into this. So sure enough, this guy does have HHT, and this is a nice AVM mimicking a solitary pulmonary nodule. And I think, Howard, you showed one of these devices that they used to close it, but this was quite a good result. You can see the AVM. He's got large feeding vessel here. And so I just saw this follow-up the other day, and you'll see that there's really nothing left of the nidus. And he has these little, the intravascular plugs, and they placed 2 of them. And so it goes from, this one's probably better. It's these little sausage-shaped things. The plug goes from here to here, inflated in the artery, and it occludes the flow. And so I show that he had this procedure done twice. He had one placed, it worked for a while, and then it recruited another artery. Here's the second one. You can see the selective catheterization, the big AVM. They placed another one of those in there. You can now see these 2 plugs, and now there's complete occlusion. And so this nidus eventually shrunk to nothing. So it's a good HHT case with the solitary nodule look on the radiograph, and then the treatment with these little plugs. So Howard, you showed one of those, right? Or am I making that up?
I think you showed a case with these particular plugs. I think multiple of them. I think. I don't know if I did. But
I've seen them before. I can't remember if I showed it or not.
You may have.
I thought somebody else had, but we do a lot of these here. And then this is just a quick one. I've never seen this before. Showed it to some of my bone friends. It's similar, at first glance you might think it's a big calcified mass or nodule, but then you realize when you look that this goes right into this posterolateral rib. Don't really see any rib until it comes out laterally here. This guy didn't have any history of cancer, and you can see it's to my eye, it's a pretty nasty looking thing. He got some periosteal bone formation, and there's blastic portions and a little soft tissue component that's enhancing here. So certainly it doesn't look like Paget's disease, doesn't look like fibrous dysplasia like we see. And he ended up undergoing PET, and it's kind of similar to the rest of the bone. Any guesses as to what this might be?
TB. No, I don't know.
It's not just a low-grade chondrosarcoma. You wouldn't be showing if it was just an ordinary low-grade.
Yeah, that's kind of what, right.
It's
if he's got something in his vertebrae too that's striated. Is this a hemangioma of some kind?
It's a they called it a vascular malformation.
Wow.
Yeah, so
Really?
I thought like you, Howard, it was going to be some sort of low-grade chondrosarcoma or something.
Yeah.
So yeah, David, I think that's a really good observation that he has hemangioma. It's one vertebral body above this rib, but yeah, this turned out to be, it was all just some, it's trabecular bone and vascular proliferation. So
Very
I have no idea. Weird lesion. So hemangioma, yeah, is what they're basically calling it.
I'm not even sure what to learn from this because it's so weird. Next time I see something like that, I'm not going to call it a hemangioma of bone. I don't think.
All those people with prostate cancer now have hemangiomas in their ribs.
I know, yeah. I apologize for showing this to you if it just confuses you more, because it certainly confused me more. So, I agree with you, Howard. I don't think there's any teaching points from this case other than
It's very curious.
We're wrong a lot.
Of course.
So, yeah. All right. Well,
we have more time if you want to show.
If anybody's been dying for a hemangioma of the bone, here you go. So that's all I have for now, Howard. I'll let you show some.
All right. Certainly my cases are, compared to yours, they're quite mundane, but I'll show them. So here's a really nice case of a really nice radiograph, actually. I'll just bring that up and give you a moment to look at it. Certainly one would start with reticular opacities in the lungs, but of course there's a lot of high attenuation, reticulation as well. So it's reticulation with, in the areas of reticulation, high opacity. So super nice example of the combination of an interstitial fibrosing lung disorder and dendriform ossifications. So one of the nicest ones that I've seen. So I just describe it as such, fibrosing interstitial lung disorder with dendriform ossifications. I don't recommend a biopsy. I think it's likely, number one, in an older person, that a biopsy is probably just going to show UIP or nothing in particular. But I think, and I tried to look at case reports of this, if you do find case reports, they tend to say something like, this is not uncommonly seen in older people. It doesn't necessarily progress like IPF, and the prognosis is good. I'm sure there are probably exceptions to that, but I just describe it as such and don't give it a label other than interstitial fibrosing disorder with dendriform ossifications and indicate that I've got many cases like that. If someone asked me in my teaching file just like this. Any other thoughts?
So sometimes these ossifications are often very immediately subpleural like this, and I've seen when they're not as plentiful as this and they're sparser, that leads to some confusion for calcified plaque, and then the lung fibrosis becomes asbestosis.
Yeah.
So, you know, any kind of lung fibrosis can give you DPO, and it's important to distinguish the calcifications from actual pleural calcifications that would make you think of asbestos plaque and then asbestosis.
Yeah. And if this was more florid, one would think of amyloid, right, if this was more florid, but yeah. Sorry, Seth?
I was just saying, I mean, how old was this patient?
This patient is, I can tell you, 77.
So, you know, since DPO happens in conjunction with UIP, I mean, not that I'm saying this is UIP, I mean, I've seen cases of UIP that have this degree of DPO.
Yeah.
So are you saying when you see this amount, you don't call it UIP, or you just correlate it with the age and the degree of underlying fibrosis, and then?
Yeah, usually in a conversation, for example, if they say, well, should we do a lung biopsy? I would say typically no, because it's an older person. In my experience, and based on case reports, this doesn't often progress substantially. And yeah, if you do a lung biopsy, you might get a pathologist to describe UIP. So
Are you saying it doesn't progress? Are you saying the calcifications doesn't progress, or the fibrosis?
Oh, the fibrosis, the fibrosing disorder doesn't necessarily progress in any substantial way in the cases that I've seen. Sometimes I've seen this as an incidental finding. They say the patient doesn't have any symptoms.
Yeah, no, I've seen it with incidental, very mild fibrosis, but I've also seen it with people with very severe UIP, not just mild fibrosis, with very who do rapidly progress and go to lung transplant, and it's a.
Oh, I've not seen that personally. Yeah.
Oh, you haven't? Yeah, and it's actually an extraordinarily common finding pathologically for them to see it, and almost every biopsy or explant of UIP, like people who go to explant, have pathologic DPO, some bone formation somewhere in their explant.
Oh, I see what you're
saying. Granulomas, they're just people have them. But I'll have to pull up some cases of that. We have some nice cases.
Okay.
There was that one case I showed a few months ago that I thought was going to be DPO, and I remember, Seth, that you had chimed in on this one too, and they did an open lung biopsy somewhere else, and it was all organizing pneumonia with intraalveolar
That was an interesting.
Bone.
Yeah, I remember that one. I showed that one around. That was interesting.
Yeah. So, but Howard, I think with this degree, some of it even looks perilobular and not just peripheral. I wonder if the patient had old organizing pneumonia or something. But we definitely see it in definite UIP patterns that progress, like Seth is saying too. This is a weird one.
Let me show you. Let me see if I actually have a comparison over time here. So I guess I don't, because the radiograph is from December 15. I thought I had another chest radiograph. So the CT is from now. So there's a year between these two. As best I can judge when I look at this comparison, the chest radiograph versus the CT done a year apart, it doesn't look like it's progressed to me, I don't think, in overall severity, I don't think, in this particular patient, I think.
Have any of you seen amyloid, like a path-proven case of amyloid, look like this?
Yes.
No. You have. I have.
No. Jonathan showed a case too that was pure DPO. There wasn't any fibrosis. It was just these little spicules and nodules of bone. And he's shown a couple of cases, and one of them was called DPO on path, and another was amyloid. So fine calcifications like this can be ossification and associated with amyloid. So DPO or amyloid. This is in the setting of fibrosis. So I think this is the metaplastic process that goes along with fibrosis. But if you have pure DPO, you have to consider amyloid as a possibility. They can look just the same.
Okay, because I do include it on the differential, but so I was just thinking, I don't know if I've ever actually seen it.
We have in this conference.
Okay.
Okay. This next one is entirely a diagnosis based on the patient's clinical presentation as well as imaging. So she presented initially with symptoms in late November and didn't get better. So this is a radiograph from then. And let's see if I have a CT now from about some days later. So in a matter of days now, we're into beginning of December. You will see that we have a lot of abnormality, diffuse in both lungs. So there's a lot of diffuse pulmonary hyperattenuation, but then lots of geographic ground glass opacities. Within some of them, we see some dilated bronchi, but I don't usually like a diffuse process when I think that bronchi are starting to dilate a bit. But she clearly was not getting better, and then she was transferred here. So that is December 1, and I will then show you, there's a lot of imaging here, but I'll go to the 15th, put that alongside. So now we have that comparison, 14 days between the two, and you'll see that now we have diminished lung volumes, and we have those geographic ground glass opacities. I'm quite impressed by what I think is true traction bronchiectasis forming in the lungs, or potentially traction bronchiectasis looking like that. And, we've seen this kind of thing in, say, fibrotic nonspecific interstitial pneumonitis, but in this patient, she started off healthy and had no connective tissue disorder. And she really just did not improve at all. So now we go to the end of December, and now you'll see that she's on a ventilator, and you'll see the same findings, but just worse. Now we see pneumomediastinum, which I ascribe to the ventilator therapy and the Macklin phenomenon. So in the absence of any other diagnosis, we made a diagnosis of just acute interstitial pneumonia. The patient did die, and I think the imaging findings and her overall clinical presentation is certainly consistent with that. This used to be called, if this is what it used to be called the Hammond-Rich syndrome, when patients would present previously healthy and really just deteriorate over a matter of weeks and then eventually die. So does everyone agree that this is a reasonable clinical and imaging diagnosis?
Yeah, it's DAD. That's
is the pathology, idiopathic.
Pretty characteristic. I think the idea that these are idiopathic still bothers me. Just that we've seen different antisynthetase syndromes, and I know David even showed the MDA5, the other myositis-related antibody that caused an acute lung injury like this. So you just wonder if she had either influenza or something that wasn't tested for, or an underlying connective tissue disease that caused this. But yeah, I mean, it fits for idiopathic if we don't know what it is.
Yeah. How old was she, Howard? How old was this woman?
This lady is 67. Previously healthy, apparently. Never had a diagnosis of a connective tissue disorder or anything before she got sick and deteriorated like this. Everything negative.
So my notion of AIP is that it's ARDS or alveolar damage, and you don't have a good cause to ascribe it to.
Yes.
Exactly.
Exactly.
Yeah, this fit.
Yes. Yes, exactly. Yeah, but this is the entity that used to be called the Hammond-Rich. Apparently, when some people went back and looked at the description of Hammond and Rich, this is the scenario. And on pathology, they think that they were describing this idiopathic ARDS, or diffuse alveolar damage, I should say. And what you see depends on when you biopsy them. So if you biopsy them in the organizing phase or the proliferative phase, that's what you see. If you biopsy them, yeah. So this patient did die soon thereafter. This one also is just a nice example of, again, a clinical and an imaging appearance. So I'll just show you a couple of cases. A patient comes in like this, multifocal consolidative opacities. And if the diagnosis is not acute infectious pneumonia, we have the differential of all the causes of non-infectious consolidation. This is what it looks like on CT done a little bit later. And we see the multifocal ground glass consolidative opacities, and they look just like that. It's kind of interesting how you have this big geographic ground glass thing. I'm trying to see if I can find an area that might qualify, maybe here, as the reverse halo sign, at least if you look at it right there, right? So in the absence of any diagnosis of an infectious illness, she was treated with steroids with a presumptive diagnosis of COP. And she did indeed get better. So she started to get better in September there. And here is an exam from October when she's better yet. Then they began to taper her steroids. I think she had some symptoms that were really disturbing. And sure enough, after they started tapering her steroids, it came back again in a different place. But overall, I think the findings are very consistent with steroid-responsive COP, imaging-wise and clinical as well.
So no known cause, nothing?
Right, yeah. And not an eosinophilic pneumonia, just presumed idiopathic COP, yeah.
And Howard, was there any biopsy or not?
There was no biopsy. I'm trying to remember if... No, there definitely wasn't a biopsy. I'm trying to even remember whether they even did a lavage or not. They may have. I can't remember.
Okay. Cool.
But they discharged her with steroids, and she did get better and then came back again. So I think they may have upped her steroids again, but I'm not sure. But I thought imaging-wise, very consistent with COP.
And no, she wasn't on any drugs that might cause a drug reaction?
Nope.
Okay. Cool.
You guys have seen this device just really quickly, but these are really sometimes hard to see because they're so faint. So let me just bring this up and zoom in a bit for you. This is the so-called Watchman device. So let me bring it up. I hope you can see it where you are, right there. And let's see on the lateral projection. Actually, I do have some zoom, so let me just bring that in there. So here is what it looks like on the frontal, and here on the lateral. There it goes. That's quite nice. So for those of you that haven't seen the so-called Watchman device in the left atrial appendage, that's what it looks like. Just a nice example of that. All right, this is kind of an interesting scenario. This patient has a tricuspid valve bioprosthesis. And she came back with tricuspid valve incompetence, and they decided to treat her with a off-label, because it's not improved for this indication. Let me see, I think the CT here just shows her tricuspid valve. So there's her bioprosthetic valve with a valve-in-valve. So they took the Sapien device for the aortic position and stuck that in the tricuspid bioprosthesis. So there we have the valve-in-valve and the Sapien inside of it. Just a nice example of that valve-in-valve. And you can find case reports of cardiologists now putting these in situations like this if they decide the patient's not a good operative candidate for replacement of the valve. Have you ever seen that one in that particular position? Anyone?
No.
No. I've seen a melody valve that they placed in the tricuspid instead of the pulmonic position, but not a TAVR.
All right.
My cardiology fellow is telling me that we have done them, though.
Okay. Is anyone else on? This one's not that exciting. I'll show it just for, it's a nice...
Howard, I can show you 2 quick cases of UIP with robust DPO.
All right.
I'm here as well now, and I've got 3 of Julie's cases I can share too.
All right. So let's quickly go to Seth, and then he'll show his, and then we'll go.
It'll take 2 seconds.
Yeah.
So here's one showing, that was explanted and showed, extensive DPO, UIP. She actually had an acute exacerbation here, and then really quickly another one. I think it's this one, who has, this is not even the one, but this one has it too. I think it might be the other one. Here we go. Yeah, where this person has, it's an old case, but you can see the DPO, and then this is a UIP pattern.
Okay.
Anyways.
One other comment is that it doesn't have to be UIP. You can get this with other kinds of lung fibrosis. I've even seen it after pneumonia and stuff like that. So it's just whatever stimulates fibroblasts can stimulate some bone formation too.
Yes.
Great. Okay, Jeff.
All righty. Let's see here. Let me turn this off. Okay, so these 3 are from Julie. She sent me one of them recently, a while ago. They won't take too long. I'll start with this one. I got to make it load it up. Hold on. And let's see. Where's the button? Can you see the radiograph, or do I have to hit the...
Yes, looks good.
No,
okay. So this is the baseline radiograph. This is 2014. You can see not terribly exciting. This is the radiograph of more interesting. And you can see there's volume loss, and there's this hazy opacity on the right. And if we go to the lateral projection, which there we go. Whoops, too far. You can see that there's this opacity here, the sharp interface, typical of a fissure, and the volume loss. So it kind of looks like a left upper lobe collapse if we're on the right. So this is an appearance of a typical right upper and middle lobe collapse. Here's the CT, and as you can see, there's the collapsed upper lobe. And as we go further down, there's the collapsed middle lobe. And let's see. Oh, no, there we go. This is from an obstructing lung cancer that was presumably invading in the airways, probably in the hilar region. You can see the vein is quite narrowed. So this was combined middle and upper lobe collapse, or obstruction is probably a better term, related to a lung cancer. So kind of looks like an upper lobe collapse when that happens together. Pretty uncommon. This is our first vascular case. So this is a guy who had about, let's see how far away is it, 1.5 years ago had an ablation for AFib and developed some dyspnea. And so, of course, one of the complications is stenosis of the veins. And indeed, you see in the left superior pulmonary vein is quite attenuated, nice normal lower pulmonary vein. And to go with it in the parenchyma, we have You can see there's patchy ground glass and a few septal lines developing, which is, when you see septal lines in a single vascular distribution, one of the things I always look for is a septal obstructing lesion. So this is presumably just some localized edema related to poor return. Sometimes you can get a little venous hemorrhage and sometimes even infarcts there, but this is a complication of this procedure. She threw some 3Ds in there as well. You can see missing the superior pulmonary vein there.
Yeah.
And then this is a cool one, which some of us have already seen that I don't think anyone in the group had ever encountered. So this is a patient, an older patient, who presents with a radiograph that looks like this. You see a hypoplastic right lung, rightward shift of the heart, elevated hemidiaphragm, and then septal lines. Looks all the world like a paroxysmal interruption of the pulmonary artery that we see. That's a developmental thing. It's contralateral to the aortic arch, which is the usual configuration. But when we look at the CT, we'll see that some gaps in the data set. But you can see there are, let's try the coronal here instead. There's a nubbin of a pulmonary artery on the right, but there isn't a pulmonary artery. But what's missing are the pulmonary veins. Let's see if I can scroll through and try it different.
On the right.
Yes, on the right. Let me go back to the axials. I think that'll do it better. Looks like some images might be missing.
Sorry, I stole the case, apparently.
That's all right. But notice these huge bronchial artery collaterals.
Yes.
No pulmonary veins at all.
Yep.
But you know what? As I look at this case, I'm not really seeing much of a right pulmonary artery either.
Yeah, there isn't much one.
Well, there is.
Yeah.
So Jeff, I've seen the contiguous images, and there is a pulmonary artery. It's a little bit small, but it's definitely there, and there's
right there
the pulmonary artery.
The 3D. There it is on the 3D.
Yeah.
Yeah, it's narrowed and small.
Yeah.
Right.
Tapers down.
Yeah. But yeah, and so I don't know. I mean, those of you who haven't, anyone had ever seen this before, and there's all these just collaterals in here. So,
which I think are venous collaterals. I think there are venous collaterals in the anterior mediastinum and in the chest wall, but there are arterial collaterals as well coming off the aorta. So
there's huge bronchial arteries. So here's my theory: could this be a sort of not a total interruption of the pulmonary artery, but a extremely hypoplastic pulmonary artery, which then led to underdevelopment of the pulmonary veins?
There was a very similar case shown in a 2001 article from Heinemann and Paige McAdams, HAR from Duke, and it showed a case that was almost identical to this, and the pulmonary artery was similarly small. I think the whole right lung is small. I think this lung did not develop normally, and that's why the pulmonary artery is small. I don't think this is primarily a pulmonary arterial problem. I think it's primarily a venous problem, and because of abnormal growth and poor circulation, the pulmonary artery never got big enough. I think the primary lesion here is venous and not arterial.
Why would the bronchial arteries then be so hypertrophic?
That I don't have a good explanation for.
Yeah,
that's how I was trying to explain that, because they get really big when the pulmonary artery, unless it's the veins that develop normally, so the lung is abnormal, so the pulmonary artery is small, and since the pulmonary is small, the bronchial arteries got big.
Yeah,
I like that.
But you don't see big bronchial arteries if you have Swire-James, even though you'll see an underdeveloped pulmonary artery in that case, just because the lung doesn't enlarge. I don't know. I'm still confused about this case, too.
Yeah. But it's cool.
Yeah.
Yeah, the article that Julie sent from Duke had cases just like this, and one of the things they showed was that there was retrograde flow from systemic arteries like the bronchial into the right pulmonary artery, and then retrograde from there into the left pulmonary artery and through the left lung with a hyperperfused left lung. And she asked the question, if you can show the lung windows, whether the subtle opacities in the left lung in this patient could be due to the effects of pulmonary hypertension. So if you look at that, there's some real small centrilobular
up there.
And I responded, yeah, I think so. It seems very reasonable. And that
these are little
so-called neovascularity of pulmonary hypertension in the left lung.
Good point.
Yeah, and those pulmonary arteries are a little on the plump side.
And I wouldn't have thought of that, but the article that she sent along with it had cases, and that's what they described. And the other thing interesting about this case is if you go to the basal medial right hemithorax, right near the pleural surface, on the mediastinal window, I thought I could see maybe a fairly fat vessel right there, traversing the pleura, a little higher there, like right there, going to essentially a periesophageal venous plexus. So it's communicating through the pleura with the mediastinal vein. And one of the patients in that article had hematemesis. So I'm thinking, wow, this could be periesophageal to esophageal and variceal because of these communications. So that's really interesting, potentially.
And go back to the lung window, you can see that there are a lot of septal lines down there, which I think are probably venous collaterals heading out to the pleura.
Oh, absolutely.
Yeah.
Yeah, absolutely.
So I think that's where the venous blood is going. It's going out into the pleura and chest wall because it can't get back to the left atrium directly.
And if you look at the fissure there, look at that fissure. I think if you had path in this patient, I would put a lot of money that the lymphatics in that lung may be really fat because they because the veins.
You know what else is interesting? Look, even the airway is small too. So I suspect that most of the blood is draining probably bronchoarterial flow because there's really just there you can see the pulmonary artery on the lung window set. It's that somehow the soft tissues is an incomplete data set, but no, there it is. You see this artery right there, and it does go there. And it is a normal pulmonary artery. It's got all three branches, but it's very small.
Very small.
Anyway, it's really cool. So thanks for her to send that to us.
Yeah, really.
All right, those are what I have for the week.
All right.
All righty. Thanks, everyone.
Thanks.
Thank you.
All right.
Yeah,
Bye, everyone.
I was unable to record or do any administrative stuff, even though I logged in with your password.